Welcome to Deep Dive Ortho, the show dedicated to exploring fascinating topics in orthopedic care. Today, we're unraveling a remarkably common yet often alarming pediatric presentation. It brings countless worried parents through the emergency department doors. Nursemaid's elbow. It's one of those conditions, I think, that once properly understood, offers clinicians immense satisfaction, both in diagnosis and treatment, often providing immediate, almost miraculous relief for a distressed child and their anxious family. Our mission today is to provide you with a really comprehensive understanding of radial head subluxation, known clinically, of course, as nursemaid's elbow. We'll be delving into its precise epidemiology, the underlying pathophysiology, what makes young children so uniquely vulnerable. Also, essential diagnostic approaches, and critically, the most effective reduction techniques. Our aim is to truly enhance your clinical practice and confidence when you're facing this condition. Joining us today to illuminate the nuances of this condition is the esteemed Professor Mo Imam. It's a pleasure to have you with us for this deep dive.
Thank you. It's a genuine pleasure to be here. It's such a prevalent yet clinically really important pediatric orthopedic presentation. Understanding nursemaid's elbow, or radial head subluxation as we should call it, truly is a cornerstone of acute pediatric care, particularly for those of you working on the front lines, in emergency settings, general practice, pediatric clinics. It's a condition where, well, a keen eye and a precise, swift action can make an immediate and dramatic difference.
That's a strong opening statement. Let's really dissect what nursemaid's elbow is at its core then. When we talk about this condition, what exactly are we defining and what's fundamentally happening with the joint when it occurs?
Well, what's truly fascinating here is the sheer simplicity of the injury's definition when you contrast it with the profound distress it causes. At its core, nursemaid's elbow is a radial head subluxation.
Subluxation, right.
Which means the radial head that's the top sort of disc-shaped part of the radius, one of the two bones in your forearm, it slips partially from its normal anatomical position. More precisely, it slips under the annular ligament.
Under the ligament, okay.
And it's absolutely crucial for clinicians to remember this. It's a partial dislocation, not a complete one.
Partial, right.
The distinction isn't just academic. It profoundly guides our diagnostic approach and, more importantly, our extremely effective management strategy. A complete dislocation implies a much higher force injury, often needs more involved intervention, whereas nursemaid's is, well, subtler and much more easily reversible.
That distinction, partial versus complete, sounds like it's a critical initial assessment point.
Yeah.
But what makes young children so uniquely vulnerable to this specific partial subluxation? Is there something inherently different about their elbow anatomy that predisposes them?
That raises a really important question about pediatric skeletal development and anatomy. And yes, absolutely, young children possess a unique anatomical vulnerability that almost perfectly sets the stage for nursemaid's elbow. You have the annular ligament, which acts like a strong fibrous ring, encircling the radial head and securely holding it against the ulna, the other forearm bone. In children, especially toddlers, this ligament's distal attachment, that's its lower end where it anchors to the ulna, is, well, weaker and noticeably thinner compared to its robust adult counterpart. Think of it as a slightly looser band, perhaps. Furthermore, the proximal end of the radius itself, the part that fits into this ligamentous ring, it's more conical in shape in young children, rather than the more cylindrical, flared shape it develops into in adulthood.
Yep.
So this combination, a slightly looser, thinner annular ligament and a more tapered radial head, makes it remarkably easy for the radial head to be pulled into the annular ligament and then become trapped there. Almost like a button getting caught in a buttonhole that's just a bit too tight.
Right. That's a good analogy.
What's reassuring, though, is that this ligament typically strengthens and becomes much more taut by around age 4 or 5. This anatomical maturation is precisely why we see a natural reduction in the incidence and likelihood of recurrence as children grow older. They essentially grow out of this particular vulnerability.
That's a very clear explanation of the transient anatomical predisposition. It makes perfect sense that as their bones and ligaments mature, the risk diminishes. Now, let's talk about the classic mechanism of injury. What's the typical scenario that brings these children into the emergency department, and what might parents describe?
The classic mechanism is quite specific and surprisingly common. It invariably involves axial traction applied to an extended arm with the forearm pronated.
The classic pull injury.
Exactly. You'll hear parents describe scenarios that, to them, seem almost innocuous or even protective. For instance, suddenly picking up a child by one hand, maybe when they're lagging behind, or perhaps pulling them by the wrist to prevent a fall down a step, or swinging them around playfully by the arms. That's quite common.
Yes, you hear that one a lot.
Less obviously, it can even happen when pulling a child's hand through a sweater sleeve or a dressing gown. That quick, forceful pull as the arm gets caught. These actions, which are often instinctive reflexes for a caregiver, can exert just enough longitudinal traction to cause the subluxation. It's important to acknowledge that parents often feel immense guilt when this happens. They might believe they've somehow harmed their child through carelessness.
Understandably.
However, it's crucial for us to reassure them. This is a common injury stemming from a specific anatomical vulnerability, not necessarily from negligence. It's simply a mechanism many caregivers aren't aware of. While these pull injuries are by far the most common, it's worth noting that less frequent mechanisms can also occur. These might include falls onto the elbow, perhaps where the arm is pronated upon impact, or sudden forceful forearm twists. In very young infants, typically under 6 months, before they are consistently weight-bearing, even rolling over onto their arm can sometimes generate sufficient traction to cause a subluxation.
Really? Even just rolling?
Yes, in the very young. The common denominator, regardless of the precise scenario, is that momentary longitudinal traction applied to the arm, especially when the forearm is pronated.
And what does that look like when the child presents in the emergency department? Because from a caregiver's perspective, it can be quite alarming and distressing, yet clinically it doesn't always present with the overt signs of trauma one might expect. It's almost a master of disguise, isn't it?
It absolutely is a master of disguise, and you have hit upon a key point there. The presentation is typically acute and, well, dramatic for the child and parent. The child experiences sudden, intense pain in the elbow and will almost immediately refuse to move the affected arm. They tend to hold it very protectively, often with the opposite hand, usually in complete or almost complete extension and pronation.
That posture, yeah.
That posture is highly characteristic and a vital diagnostic clue. What can be profoundly confusing for caregivers, and indeed for less experienced clinicians, is the typical lack of obvious physical signs. The things you'd expect with a fracture or a more severe injury.
Right. No swelling, no bruise.
Exactly. There's usually no visible swelling, no bruising ecchymosis, and no obvious deformity. The skin looks normal, the joint appears anatomically intact on visual inspection. This stark contrast between the child's acute distress and the lack of overt physical signs can be incredibly unsettling for parents. Another important nuance is that the pain, while localized to the elbow, can sometimes be referred.
Referred where?
To the wrist or forearm. I've seen cases where initial assessment was misled because the child is pointing to their wrist or even their shoulder due to referred discomfort.
Ah, okay. That's a potential pitfall.
It is. This is why a thorough understanding of the typical presentation combined with a focused physical exam is so crucial. Despite the pain and refusal to move, distal circulation, sensation, and motor ability should all be intact, though cooperation with a full neurological exam can understandably be challenging in a distressed toddler.
Of course.
The pain, when it exists, is generally localized to the radial head area when palpated very gently. But the real pain comes from any attempt to move the arm, particularly supination or flexion.
That referred pain point is crucial for an accurate diagnosis, potentially saving valuable time and avoiding unnecessary investigations. Moving on to epidemiology then. Who is most commonly affected by nursemaid's elbow? And are there any interesting patterns we see in terms of which arm is more frequently involved, or even a surprising association that clinicians should be aware of?
Right, the demographics. Nursemaid's elbow is overwhelmingly common in young children, predominantly occurring between 1 and 4 years of age. A significant large-scale emergency department study provided some really precise data on this. They found the average age at diagnosis to be exactly 28.6 months.
So around 2.5 years old?
Precisely. Furthermore, a substantial proportion, nearly half, 44%, actually occur within a narrower age bracket of 18 to 29 months.
Really highlights that toddler stage.
Absolutely. It highlights the peak vulnerability during the toddler and preschooler years, exactly when children are most mobile, but their ligaments are still developing. While it becomes progressively less common as children get older due to that ligamentous strengthening we discussed, it can still affect children up to 6 or even 7 years old. So you shouldn't rule it out based purely on age if the mechanism fits.
So it's truly a condition of that very active toddler and preschooler stage. Is there any gender predominance we typically observe?
Yes, there is a slight female predominance. Approximately 60% of reported cases occur in females.
Interesting. Any idea why?
Well, the precise reason for this isn't fully elucidated in the literature. Research is still exploring whether this is due to subtle behavioral differences between genders, perhaps variations in play patterns or how they typically interact with caregivers,
Mhm.
or if there are minute yet predisposing anatomical factors at play that slightly favor females. It remains an open question, really, though the predominance is consistently observed in studies.
And what about laterality? Does it tend to affect one arm more than the other?
Interestingly, yes, the left arm is affected more often than the right, again around 60% of the
Your
time.
left arm more often.
Yes. The common hypothesis here is quite practical and relates directly to caregiver behavior. It's thought to be due to the fact that most adults are right-handed.
Ah, I see where this is going.
Exactly. This makes them more likely to naturally hold a child's left hand when walking, leading them or pulling them along or lifting them. This tendency, in turn, puts the child's left arm at a greater risk for that critical axial traction mechanism. It's a simple, yet compelling explanation for the observed laterality.
That's a fascinating observation, a real-world behavioral link to the injury. Now, you mentioned a surprising association earlier, something truly significant that perhaps goes beyond just orthopedics. What is that?
Yes, this is where one particular study, the Vitello study from 2014, truly offered a pivotal, perhaps even revolutionary insight. To my knowledge, it was the first study to explicitly illustrate a clear and highly significant association between nursemaid's elbow and elevated body weight in children.
Elevated body weight, really?
Yes, and this isn't just a minor correlation. The data are quite compelling. The study revealed that the majority of patients affected specifically 53% of females and 61% of males were above the 75th percentile for weight.
Oh, wow, that's over half.
It is, and it gets even more striking. More than 1/4 of all affected children were over the 95th percentile for weight.
Hmm.
That's 27% of females and 33% of males falling into this highest weight category.
That's a profoundly compelling piece of data. It almost suggests nursemaid's elbow could be a physical red flag in the emergency department for something broader. How does that discovery change the conversation we have with families in the clinic beyond simply fixing the elbow?
You've articulated it perfectly. It's precisely a clinical red flag, or perhaps even a clinical gift wrapped in distress. The implications of this finding are far broader than just the orthopedic injury itself. For clinicians, particularly emergency physicians, GPs, pediatricians who are often the first point of contact, this connection between a common musculoskeletal condition and elevated body weight underscores a wider fundamental responsibility.
A responsibility to discuss weight.
Well, yes, but carefully. In the chaos and speed of a busy emergency department, it's often challenging to initiate sensitive conversations about childhood health and lifestyle. Weight management, physical activity, healthy eating patterns.
Absolutely. Time is always pressured.
But nursemaid's elbow, with this established link to elevated body weight, provides a direct, tangible, and acute reason to begin that crucial dialogue. It's not just a joint injury, it's an entry point. It provides an immediate, non-judgmental context. You can say, we've fixed your child's elbow, which is a common injury, and we've observed a correlation with elevated body weight in recent studies. This is an opportune moment to perhaps discuss general healthy lifestyle habits for your child's overall well-being.
Framing it that way makes sense.
Exactly. This study was pioneering in making that link explicit for nursemaid's elbow, transforming a seemingly minor orthopedic issue into a unique public health opportunity, especially given the rising prevalence of childhood overweight and obesity. It's an opportunity to provide comprehensive care that extends beyond the presenting complaint.
That's certainly something to reflect on, turning a moment of acute care into a broader health intervention. Let's move on to how we actually go about diagnosing this condition. Section 2 is all about clinical assessment and diagnostic nuances. How do caregivers typically describe the incident, and what characteristic findings do we look for on physical examination once the child is in front of us?
A thorough history is paramount here, even if it's not always straightforward to get. Caregivers may not always be aware of the exact moment or the precise incident that caused the subluxation. In fact, it's quite common for them to describe what seems like a very innocuous act.
Like just picking them up?
Precisely. They might recount the child's arm being pulled upwards by the wrist, or perhaps the child being swung around playfully. Sometimes, symptoms might even appear after what initially seems like a simple fall onto an outstretched arm, where the arm might have twisted during the impact. The key is to elicit any history of longitudinal traction, a sudden pull, or a twisting motion, regardless of how minor the parent perceives it to be. Our role is to listen without judgment, understanding the distress and potential guilt parents might be experiencing.
And what are those telltale physical signs once the child is in front of you that really point towards nursemaid's elbow?
On physical examination, the child will very typically protect the affected arm, often holding it quite rigidly with the opposite hand and positioning it in complete or almost complete extension and pronation.
That classic posture again.
It's highly characteristic. While the child will visibly resist any attempt to move the arm and can become quite distressed and cry during the examination, which is entirely understandable.
Of course.
There is generally no pain unless the arm is directly manipulated or specific movements like supination or flexion are attempted. Crucially, and this can be the most confusing aspect for both parents and less experienced clinicians, you won't typically find visible signs of significant acute trauma.
No bruising, no swelling.
Correct. There's an absence of ecchymosis, which is bruising, no erythema or visible redness, and importantly, no significant edema or swelling around the joint. The joint itself usually appears outwardly normal. Distal circulation, sensation, and motor ability, checking their pulse, feeling for warmth, asking about numbness or tingling, maybe getting them to wiggle their fingers should all be intact.
Though, may be hard to assess properly.
Exactly. Getting full cooperation for a precise neurological exam from a distressed toddler is a significant challenge. When you gently palpate the radial head area, there might be some localized tenderness, but the primary indicator remains the refusal to use the arm and the child's characteristic protective posture.
It sounds like the absence of those more obvious signs of injury can sometimes be misleading. What happens if the arm seems to get better on its own before they even reach you in the clinic? Does that happen often?
That's a great point, and yes, it absolutely does happen. Quite frequently, actually. The radial head subluxation can spontaneously reduce before the child is even seen by a healthcare professional.
How?
It often occurs during transit to the hospital, maybe due to a subtle movement in the car seat, or even as the child is undressed for examination. A slight manipulation can sometimes pop it back in. In such cases, parents will report a sudden, almost miraculous disappearance of symptoms. The child, who moments before was in acute distress, will suddenly start using the arm normally again as if nothing had ever happened.
That must be quite confusing for parents.
It can be incredibly disconcerting for them. The sudden resolution can seem almost unbelievable after such acute distress. Our role, even if the arm is now moving freely, is to conduct a thorough physical examination to confirm the resolution. And, most importantly, to provide comprehensive reassurance to the parents about the diagnosis. They need to understand precisely what happened, why it happened, and crucially, how to prevent recurrence, even if the issue resolved itself before they arrived.
That educational piece is vital.
Absolutely, vital for preventing future episodes.
That reassurance must be incredibly valuable for anxious parents. Now let's discuss imaging. When should we consider radiography, and what do we typically expect to see on an X-ray in a case of nursemaid's elbow?
This is a crucial area for effective, efficient clinical practice, especially in busy emergency departments. The consensus among pediatric orthopedic specialists and emergency medicine professionals is clear. Nursemaid's elbow is primarily a clinical diagnosis.
Clinical diagnosis first.
Absolutely. It's based entirely on that characteristic history you gather from the caregiver and the physical examination findings. Therefore, pre-procedure X-rays are generally not needed for a straightforward presentation. This policy is incredibly important as it saves valuable time, conserves resources, and most critically avoids unnecessary radiation exposure for the child.
Always a key consideration in pediatrics.
Always.
So, when are X-rays warranted? What are the key red flags or atypical presentations that signal we absolutely need to image before attempting any reduction?
Okay, X-rays are indicated in specific scenarios where you have a genuine concern about a more serious underlying injury. Firstly, if there's any suspicion for a fracture, well, this might be evidenced by clinical findings, atypical of nursemaid's elbow, severe pain that doesn't fit the picture, significant bruising, visible swelling, or any obvious deformity beyond that subtle protective posture. Secondly, imaging is warranted if the mechanism of injury is atypical. For instance, not the classic pull scenario, but a direct impact or a high-energy fall. If the history of injury is unclear, or if you simply cannot get a reliable history from the caregivers, an X-ray provides crucial information. Furthermore, in children older than 6 years of age, other injuries, including various types of fractures or more complex dislocations, become statistically more likely.
So age is a factor too.
Yes. So X-rays are often considered in this older age group to rule out these possibilities. And regrettably, if there are any concerns about non-accidental trauma, imaging is absolutely necessary. not only for diagnostic purposes, but also for crucial safeguarding reasons.
Of course.
In essence, any significant deviation from the classic presentation should prompt you to get an X-ray.
And when we do image in those specific indicated situations, what are we usually looking for, or perhaps not looking for, in a true nursemaid's elbow?
In cases of genuine nursemaid's elbow, the X-rays are typically normal, completely normal.
Okay.
The subluxation of the radial head beneath the annular ligament is a soft tissue injury, and ligaments are not visible on plain film X-rays. Occasionally, you might observe a very subtle displacement of the radiocapitellar line on the plain film X-rays.
The radiocapitellar line.
Yes, that's an imaginary line that should run directly through the center of the radius and align perfectly with the capitellum, a key anatomical landmark in the humerus. If that line isn't perfectly aligned, it can hint at an issue, but it's not consistently present nor necessary for diagnosis, and often requires a very experienced eye to spot.
So not a reliable sign.
Not really. The main purpose of imaging in these indicated scenarios is simply to rule out other, potentially more serious conditions like a fracture or a complete dislocation, rather than to confirm the diagnosis of subluxation itself. It's a rule-out tool, not a primary diagnostic one for nursemaid's elbow. This helps prevent missed fractures and guides appropriate management for more complex injuries.
That clarifies the role of imaging perfectly. Now, for the part that brings such immediate relief and often feels like magic for the distressed child, the reduction techniques. Section 3 focuses on effective reduction, evidence, and practice. What's the core principle of closed reduction for nursemaid's elbow, and what should we communicate to patients and their families before we even start?
The principle is remarkably simple, swift, and, as you say, immensely satisfying. Treatment for nursemaid's elbow involves closed reduction. That means we manually maneuver the bones back into place without needing any surgical incision.
No surgery needed.
Correct. The beauty of this is that the maneuver can often be performed in a matter of seconds without the need for any sedation or pain relief. This is a significant advantage, particularly in a busy ED, as it avoids the delays and risks associated with administering analgesia or procedural sedation to a child. When speaking with parents, which is a vital first step, it's crucial to explain precisely what you're about to do and what they can expect.
Managing expectations.
Absolutely. You must tell them that while the procedure is brief, it may cause transient sharp pain as the annular ligament repositions itself around the radial head. However, and this is the most important part to convey, you must reassure them that this pain should resolve almost immediately afterwards. The child should typically experience rapid relief and quickly begin using their arm again. Clear, empathetic communication is absolutely key to a smooth process and a positive experience for both the child and their anxious caregivers.
And how do we best position the child to facilitate this procedure, both for their comfort and to enhance cooperation during what can be a frightening moment for them?
For optimal positioning, we always suggest having the child next to a caregiver, or ideally, sitting securely on their lap.
On the parent's lap is usually best, isn't it?
Usually, yes. The caregiver can then gently, yet firmly, hold the child's torso and unaffected arm. This positioning does several things. It enhances comfort for the child, provides a sense of security during a potentially frightening moment, and often promotes cooperation by making them feel safe and supported. It also gives the clinician a stable base from which to perform the maneuver effectively. It's about creating an environment of calm and control, even amidst the child's initial distress.
Let's get into the specifics of the two primary techniques. Hyperpronation versus supination-flexion. Could you walk us through the step-by-step for the hyperpronation method first?
Certainly. The hyperpronation method is often considered the first-line approach due to its evidence-based success rates. Here's how you perform it. First, you'll hold the affected elbow in one of your palms, cradling it. Then place your thumb, or sometimes your index finger, over the radial head itself. That's the bony prominence just below the elbow joint, which you can often feel rotating when the forearm is moved.
Okay, thumb over the radial head.
Correct. With your other hand, you then firmly but gently grasp the child's wrist. You want to maintain the elbow at approximately 90 degrees of flexion throughout the maneuver. From this position, in one swift controlled motion, you rapidly hyperpronate the forearm.
Hyperpronate, so turning the palm down further.
Exactly. Pronating beyond the normal range of motion, turning the palm to face downwards even further than it usually would. Some experts also recommend immediately following this hyperpronation with further flexion in the elbow, bringing the forearm towards the shoulder. That can sometimes assist in the final reduction. As you perform this, you might feel a distinct, palpable click or pop over the radial head as the ligament slips back into place.
The click.
Yes. While this sensation is often a good indicator of successful reduction, its absence doesn't necessarily mean the maneuver has failed. The child's subsequent return of function is the ultimate arbiter.
And how does the supination-flexion method, the other main technique, differ in its execution?
With the supination-flexion method, you again start by applying slight gentle pressure to the radial head with your thumb while supporting the elbow with the same hand. You then grasp the patient's distal forearm, the wrist area, with your other hand. The maneuver is performed in one continuous fluid motion. You rapidly and firmly supinate the forearm, turning the palm upwards.
Palm up this time.
Yes. As you complete the supination, you then fully flex the elbow, bringing the hand towards the shoulder while maintaining gentle traction along the arm. Similar to the hyperpronation method, a distinct click or pop may be felt or even heard upon successful reduction. Again, it's a helpful sign, but not an absolute prerequisite for success. Both techniques rely on slightly different biomechanical principles to disengage the radial head from the trapped annular ligament, but the goal is the same: to get that ligament back where it belongs.
Both sound like very precise movements requiring a gentle but firm touch. Is there robust evidence to suggest one technique is more consistently effective or perhaps less painful than the other for the child?
This is where evidence-based practice truly shines and guides our clinical decisions. Robust evidence, particularly from comprehensive Cochrane systematic reviews last updated in 2017 and 2012, synthesizing multiple randomized controlled trials, consistently indicates that the hyperpronation method results in significantly less failure at the first attempt.
Less failure with hyperpronation.
Yes, compared to the supination-flexion method. For instance, the data show a remarkable difference, typically a 9.2% failure rate for hyperpronation versus a considerably higher 26.4% for supination-flexion.
That's quite a difference.
It's a very clear statistical advantage. To put that into a more clinically relatable context, the impressive number needed to treat, or NNT, is 6 for hyperpronation.
NNT of 6. What does that mean exactly?
What that means is you need to treat only 6 children using the hyperpronation method instead of the supination-flexion method to prevent 1 additional first-attempt failure. Essentially, for every 6 patients you treat with hyperpronation, you'd expect 1 more successful reduction on the very first try compared to using the alternative method.
Okay, so it's more efficient first time.
Exactly. It's a very efficient way to ensure a quicker resolution.
That's a very clear statistical advantage in terms of first attempt success. What about the child's experience of pain during the procedure? Does the evidence weigh in on that too?
The evidence regarding pain perception is of lower methodological quality compared to success rates, admittedly. But it does suggest that the hyperpronation technique may also be less painful for children.
It's less painful as well.
Potentially. This is thought to be because hyperpronation might cause less stretching or impingement of the annular ligament during the maneuver. So, given its higher success rate and potential for less discomfort, hyperpronation is increasingly recommended as the initial reduction maneuver in clinical practice guidelines. It offers the best chance for immediate success and minimizes the child's distress.
So hyperpronation is a first line. If that first attempt isn't successful, what's the recommended next step for clinicians?
If your first attempt with one technique is unsuccessful, and it's important not to get discouraged if it doesn't work straight away, the logical and evidence-supported next step is to attempt the alternative technique.
Switch methods.
Precisely. So if you started with hyperpronation and it didn't reduce, then you would switch to supination-flexion. Conversely, if supination-flexion was your first choice and failed, you try hyperpronation. There's some very low-quality evidence that suggests repeat pronation if you're attempting a second maneuver after an initial failure with hyperpronation may be slightly more effective than trying repeat supination-flexion. But the general principle is to switch. Ultimately, the confirmation of a successful reduction isn't solely dependent on hearing or feeling that click or pop.
Right. The click isn't everything.
No. While those are helpful indicators, the true gold standard and the endpoint we are aiming for is the immediate cessation of pain and the child's spontaneous return to using the affected arm. When you see that arm start to move freely, often reaching for a toy or their parent, that's your definitive sign of success.
The child's functional recovery is truly the gold standard, providing that immediate and powerful confirmation. Let's move to post-reduction care and prognosis in Section 4. What's the immediate management like after a successful reduction? And what if, after a few minutes, the child still isn't moving their arm?
After a successful reduction, it's absolutely normal for a child to cry for a few minutes.
Even if it worked.
Yes. This isn't usually due to persistent pain from the elbow, but rather from the acute distress of the event itself, the sudden injury, the trip to the hospital, the unfamiliar faces, and the brief, though sharp, discomfort of the reduction maneuver. Because the pain from the subluxation resolves so rapidly with successful reduction, analgesia is typically unnecessary. It's quite remarkable how quickly they bounce back once the mechanical issue is resolved. Our immediate management then shifts to an observational period.
Watching and waiting.
Essentially, yes. We recommend allowing the child some quiet time to spontaneously begin using their arm. This might involve stepping out of the room for a few minutes to give the family some private space and a sense of calm, or, more actively, offering a favorite toy, a comfort item, or a small snack can often encourage them to reach out and use the arm.
The biscuit test.
Exactly. Most children will start using the arm spontaneously or in response to gentle encouragement within 30 minutes. In fact, it often happens much sooner, typically within 5 to 15 minutes of a successful reduction. The moment they reach for something, you know you've succeeded.
What's the care plan if after that 30-minute observation period, the child still isn't moving the arm despite your best efforts?
Okay, if the child does not begin to move the arm spontaneously after that 30-minute observation period, we need to have a clear and systematic care plan in place. The first step would be attempting reduction a second time.
Try again.
Yes, utilizing the alternative technique if the first attempt failed. Remember, some cases might be slightly more resistant, and a different approach could be successful. If function is still not regained after a second attempt, or if there was any doubt about the initial diagnosis, obtaining an X-ray of the elbow prior to discharge becomes warranted.
Image at that point.
Yes. This helps to check for any other underlying injuries, such as a subtle fracture that might have been missed, or perhaps an unrecognized complete dislocation. Or to confirm if the reduction itself was truly unsuccessful, and the radial head remains subluxated. If imaging is normal, but the arm function isn't regained after 2 attempts, then placing the arm in a comfortable sling for a short period might be considered to provide comfort, and the child should be referred to an orthopedic surgeon for further evaluation and management.
Okay, referral if still not moving.
Yes. And it's important to clearly communicate with the family that if the child is not using the arm fully upon arrival home, they should return or see their family doctor promptly. A key point to reiterate here is that if reduction is successful, no splinting or sling is required.
No need to immobilize.
No. The arm should be fully functional almost immediately, and we don't want to restrict that return to normal movement.
That sounds like a very structured, stepwise approach to ensure no injury is missed. And what about the long-term outlook and prevention strategies? Is recurrence common, and what's the most crucial advice we can give caregivers to help prevent it?
The prognosis for nursemaid's elbow is truly excellent when it's promptly and successfully reduced. It's very reassuring for families. It's rare for there to be any long-term sequelae or permanent damage to the joint or arm function. This is a condition with a very high success rate for full recovery. However, recurrence is certainly possible.
How common is it?
It occurs in approximately 20% of patients. This recurrence isn't believed to be due to residual damage from the initial injury, but rather a reflection of the underlying anatomical predisposition.
That weaker ligament again.
Exactly. That slightly looser or thinner annular ligament we discussed. If a child has one episode, they might be inherently more susceptible to another, given the right mechanism.
And does that anatomical vulnerability change as the child grows older, offering a natural resolution to the recurrence risk?
Yes, absolutely it does. As children grow and develop, their arms strengthen, and crucially, the annular ligament itself matures and tightens around the radial head. This anatomical maturation typically happens by around age 4 or 5.
So they do grow out of it.
They do tend to grow out of it, yes. So while recurrence is possible in the toddler years, the risk significantly diminishes as they approach school age, making them progressively less susceptible to this particular injury. This is a very comforting piece of information for parents who worry about repeated episodes.
That's a good piece of information for parents. Given the potential for recurrence and the common mechanisms, what's the single most crucial advice we, as healthcare professionals, can impart to caregivers for prevention?
A vital part of our management, and indeed our broader responsibility, is comprehensive education for parents and caregivers about the risk of recurrence and, crucially, very clear, actionable advice on how to prevent it. We need to empower them with practical knowledge. The core message is simple. Never pull, tug, or swing a child by their hands, wrists, or forearms.
Avoid the pulling actions.
Absolutely. This applies to seemingly innocent play, like swinging them between two adults or even reactive protective actions. Be specific with your advice. When lifting a child, always do so from under the armpits, ensuring the traction is on the shoulder girdle, not the elbow joint.
Lift under the arms, not by the hands.
Correct. When dressing a child, especially with sleeves that might be a bit tight, advise them to gently push or guide the clothing over the child's arm, rather than pulling the child's arm through the sleeve. It's essential to explain that even seemingly protective actions, like instinctively pulling a child by the arm to prevent a fall down a step or quickly pulling them away from a hazard, can inadvertently cause this injury.
Because of that specific vulnerability.
Precisely. Emphasizing these preventative measures, patiently and empathetically, is key to significantly reducing the incidence of recurrence. It's about educating without shaming.
That's invaluable practical advice for anyone caring for young children. Moving on to Section 5, let's talk about differentiating nursemaid's elbow from more serious conditions and understanding complex cases like complete radial head dislocation. What are the key differential diagnoses we should immediately consider when a child presents with elbow pain and refusal to move their arm, especially if the history isn't perfectly classic?
It's absolutely vital for clinicians to maintain a broad differential diagnosis, particularly if the history isn't perfectly classic for nursemaid's elbow, or if there are any red flags. Common conditions that might present similarly and therefore require careful differentiation include various types of fractures around the elbow and forearm.
Fractures. Okay. Like what?
For instance, a simple elbow fracture, a wrist fracture, a green stick fracture, that partial break common in children's flexible bones, or perhaps a supracondylar fracture, a break in the humerus just above the elbow. These are particularly concerning due to potential neurovascular compromise. More complex possibilities include a Monteggia fracture.
Monteggia. That's the ulna fracture with radial head dislocation.
That's the one. A specific and crucial combination. It's distinct from nursemaids because the radial head is fully dislocated and the ulna is fractured.
So a fracture needs to be top of mind, especially the more complex ones. What else should we be thinking about when evaluating these children?
Beyond fractures, we must broaden our scope to consider other types of injuries and conditions. This could include a simple hand injury where the pain is referred, or more generalized soft tissue damage around the hand or elbow area. Less common, but critical to rule out, are infections.
Infections like septic arthritis.
Yes, septic arthritis in the elbow joint, bursitis, or an elbow joint effusion, which is fluid accumulation. In rare, more insidious cases, osteomyelitis, a bone infection, or a deep soft tissue abscess could mimic symptoms. It's also crucial to consider potential neurological injury, where the child's refusal to move the arm might stem from nerve involvement rather than a direct musculoskeletal injury.
And the possibility of non-accidental injury.
Regrettably, yes. In any case of an atypical mechanism or presentation, especially if the history doesn't quite add up, the possibility of non-accidental trauma must always be in our differential and thoroughly investigated for safeguarding purposes.
Those are critical distinctions, and some of those are significantly more serious than a nursemaid's. What are the absolute red flags that tell us this isn't just a straightforward nursemaid's elbow and warrants immediate, deeper investigation, typically with imaging?
Right, the red flags. The presence of any physical signs beyond what's typical for nursemaid's elbow should immediately raise concern. These include severe pain that doesn't resolve instantly with attempted reduction, or pain that is disproportionate to the typical presentation. Obvious bruising, significant and visible swelling of the joint, or any palpable or visible deformity of the arm that extends beyond just the radial head's position.
Swelling and deformity are key.
Absolutely. And neurovascular compromise. That means any altered sensation in the hand or fingers, or impaired circulation distal to the injury, a pale, cold, or pulseless hand. That's a major, urgent red flag requiring immediate attention. And as we discussed, if the mechanism of injury is unclear, doesn't fit the classic pull narrative, or is inconsistent with the child's developmental stage, or if the history simply doesn't quite fit, further evaluation, including imaging, is necessary before even considering an attempt at reduction.
Trust your clinical intuition.
Definitely.
That's a comprehensive list of red flags. That brings us to a very distinct entity, complete radial head dislocation. How does this fundamentally differ from the subluxation we've been discussing as nursemaid's elbow, and what are its common associations?
This is a crucial distinction. Their management is poles apart. Nursemaid's elbow is a subluxation, a partial dislocation, typically from a relatively low-force axial traction injury, the pulled elbow. A complete radial head dislocation, however, is significantly less common and far more severe. It generally results from high-force trauma, a much greater energy impact than what causes
Ooh,
nursemaids.
high force injury.
Yes,
Yeah.
and crucially, unlike nursemaid's elbow, a complete radial head dislocation is almost invariably associated with other major injuries. It's these associated injuries that often dictate the immediate management and long-term prognosis. Common associations include Montagia fractures, that combination of radial head dislocation, and an ulnar shaft fracture we mentioned.
Right.
This injury often renders the forearm unstable and requires careful reduction of both components. Another severe association is the terrible triad injury of the elbow.
Terrible triad. Sounds bad.
It is. It's a complex and devastating injury involving a radial head fracture, an ulnar coronoid process fracture, and a complete elbow dislocation. These are clearly far more complex and severe than a simple nursemaid's elbow.
Are there any other types of radial head dislocations that aren't traumatic, perhaps congenital?
Yes, very rarely you can encounter congenital radial head dislocations. These are usually present from birth or early development, often posterior in direction, and frequently bilateral, affecting both elbows.
Bilateral. Okay.
What's interesting about congenital dislocations is that they may actually be asymptomatic or cause very little pain until adolescence, when activity levels increase or the deformity becomes more noticeable. These are typically associated with other systemic congenital anomalies like Ehlers-Danlos syndrome, Knell-Patella syndrome, ulnar dysplasia, things like that. They're generally identified on physical exam by prominence of the radial head and often a limited range of elbow motion, particularly in extension and supination.
So nursemaids is a quick, simple fix. But what about the management of these complete dislocations, especially the traumatic ones? It sounds like a much bigger undertaking.
The management differs dramatically, yes, which underscores the importance of accurate diagnosis. While nursemaid's elbow is managed by simple manual closed reduction, complete radial head dislocations, especially traumatic ones, require far more complex interventions.
Yeah.
In children, if there's an associated ulnar fracture, like a Montagia closed reduction of that ulnar fracture, might also reduce the radial head. This reduction is then followed by prolonged immobilization, typically a long arm cast at 90 degrees elbow flexion for about 6 weeks.
6 weeks in a cast.
Yes, to allow for bone healing and ligamentous stability. However, in adults, complete radial head dislocations, particularly those without a clear associated fracture, almost invariably require open surgical repair.
Surgery for adults, usually?
Almost always. The approach is entirely different because the underlying pathology, often a severely torn annular ligament or other soft tissue structures, is much more extensive and requires direct surgical repair. It's a completely different league of injury.
And what's the long-term prognosis for a complete radial head dislocation compared to the excellent outlook for nursemaid's elbow? It sounds much more guarded.
You're absolutely right. The prognosis is much, much more guarded. Unlike nursemaid's elbow, where full recovery is the norm, delayed diagnosis and correction of complete radial head dislocations can lead to significant problems. Chronic pain, significantly reduced range of motion and mobility, the early onset of osteoarthritis in the elbow joint, and even persistent radial head deformity.
Serious long-term issues.
Potentially, yes. These complications can unfortunately necessitate complex corrective surgery down the line, sometimes years later. Prompt, accurate diagnosis and immediate intervention, whether through closed reduction with casting or open surgical repair, significantly improve outcomes and minimize these long-term complications. This truly highlights why early and accurate diagnosis is so critical in these more severe cases.
That really drives home the importance of distinguishing these conditions quickly and accurately. Finally, let's bring it all together by discussing the interprofessional approach to care in Section 6. Why is a truly collaborative model so important for optimal outcomes, not just for nursemaid's elbow, but for other radial head pathologies as well?
A cohesive, well-coordinated interprofessional team is absolutely crucial for the optimal diagnosis, management, and indeed the long-term outcomes of nursemaid's elbow, and even more so for all other radial head pathologies, from simple sprains to complex dislocations and fractures. No single clinician works in isolation, especially in acute care.
It takes a team.
It really does. This team typically includes emergency department physicians and nurses, primary care providers, GPs, pediatricians, orthopedic surgeons, nurse practitioners, and for more complex cases, physical therapists and pharmacists. Effective communication and seamless collaboration among all these team members are paramount to ensure accurate diagnosis, prompt treatment, and the best possible long-term outcomes for patients. It's truly a chain of care, and each link is vital.
Can you elaborate on the specific roles and responsibilities within this team? Who does what, especially in the acute setting when a child first presents?
Of course. Let's start with the nurses. They play an absolutely crucial role, particularly in busy emergency settings. Through initial assessment, meticulous history taking, and efficient triage. They are often the first to identify the characteristic presentation and can begin building rapport with distressed families.
Crucial first contact.
Yes, emergency physicians and nurse practitioners are frequently the next point of contact, capable of making the swift clinical diagnosis and performing the immediate close reduction for nursemaid's elbow, providing that near-instant relief we discussed. They also make the critical initial decision on whether imaging is required based on red flags. Orthopedic surgeons become essential for managing recurrent cases, for any complex presentations where there's diagnostic ambiguity or if the initial reduction is unsuccessful. Or, crucially, when other more serious injuries like fractures or complete dislocations are suspected or confirmed.
They handle the complex stuff.
Exactly. They lead the surgical management of complete radial head dislocations, which are far more involved. Pharmacists provide critical support, not just for pain management strategies in more severe cases, but also for medication reconciliation, especially in adult post-surgical cases.
And physical therapists.
PTs are integral for postoperative and rehabilitation care in more complex cases or after fractures, guiding patients through prescribed range of motion exercises to regain full function and prevent long-term stiffness or weakness. The key takeaway is that early detection and intervention, facilitated by seamless communication and collaboration across all these disciplines, are consistently linked to better prognosis across the entire spectrum of radial head injuries.
That truly paints a picture of comprehensive, coordinated care where every member of the team contributes to the best possible patient outcome. Professor, we've taken a deep dive today into nursemaid's elbow. We've understood its calming presentation, the specific anatomical reasons it occurs in young children, and those highly effective, simple manipulative techniques that bring such swift relief. We've also explored the important epidemiological insights, including that novel and significant association with elevated body weight, and the crucial distinctions for more complex and potentially devastating elbow injuries like complete radial head dislocations. If you found this deep dive valuable, please do consider rating and sharing the show. It truly helps us reach more medical professionals like you and share these crucial insights. As we consider nursemaid's elbow, a seemingly minor injury with such a dramatic presentation and a remarkably simple, almost magical fix, it serves as a powerful reminder, doesn't it, of how profound our understanding of pediatric anatomy and a well-executed maneuver can be. It highlights that sometimes the simplest presentations in medicine can offer the most profound clinical opportunities, even prompting us to consider broader health implications beyond the immediate complaint. What other simple presentations might we be overlooking deeper complexities or unique intervention points in? And how can we continue to refine our clinical intuition in the busiest of settings to truly leverage every patient encounter for holistic care?